we are really delighted that you're joining us this morning in this webinar organized by the psychiatry section of the UEMS, the European Union of Medical Specialists, and the European Division of the Royal College of Psychiatrists. So I'll start by introducing myself. My name is Angela Carboledo, and I am the current chair of the European Division of the Royal College, and I work as a consultant psychiatrist in North Dublin in Ireland. So I'll take this opportunity to encourage you all to maybe have a look at the website of the Royal College, to get familiar with the work of the international divisions and the international strategy of the college. And hopefully at some stage you may decide to join us. We do have a fantastic program this morning discussing the effects of COVID-19 and the pandemic on patients with severe mental illnesses, who are very much at the center of the work that we do clinically on a daily basis. I would like to thank our speakers for agreeing to present this morning. I think their presentations are going to stimulate debate and give us some food for thought. And of course, a very special mention to Dr. Adrian James, the current president of the Royal College, who is going to be our moderator. It's fantastic having you here, Adrian. I would also like to thank Sarah and Agnes from the college for their help organizing the event, the technical support, the admin support. And without any further delay, I will introduce my colleague, Dr. Marisa Casanova-Diaz, who has been a co-organizer also, and who is the current president of the psychiatry section of UEMS. She's also a research fellow and a consultant psychiatrist at Cardiff University. Thank you, Marisa.
Thank you very much, Angela, and thanks everyone for being here. So just a brief introduction to UEMS. UEMS stands for European Union of Medical Specialists, which represents all medical specialists across Europe. So more than 50 medical specialties, and one of them is our own psychiatry specialty, and I'm the president of the section of psychiatry. What UEMS, so the purpose of our section is to promote the highest standard of care for people with mental illness and throughout Europe, and to do that through postgraduate training and through the continuous medical education of psychiatrists. And like Angela, I'd like to invite you to visit our website, uemspsychiatry.org, and to learn more about the work that we do. So we're delighted to have Dr. Adrian James to moderate today's session. Adrian is a true friend of International. He has been a very vocal advocate for prioritizing severe mental illness patients for vaccinations. And it's an honor to have you facilitate today's discussion, and thank you for giving up our time for us.
Well, thank you, Marisa, and thank you, Angela, for the introduction, and more importantly, for all the work that you do. It's you lead two organisations that have been incredibly influential. So thank you so much. I'm Adrian James. I'm president of the Royal College of Psychiatrists, coming to the end of my term, a 3-year term, which has really coincided with the whole of the pandemic. And I'm delighted to be moderating this session. It'll last for 75 minutes. Please, if you've got any questions, use the Q&A function you can see on your screen. If we don't get to all the questions, then please keep the questions coming, and Sarah will collate them and send them off to our speakers, so we'll get the answers back to you. If you would like a CPD certificate, again, please email Sarah. Her email address is in the chat. Please use this as an interactive session. So I'm absolutely delighted we're having this session. Of course, it's interesting in its own right, but it's very important that we learn lessons both for future pandemics, but also the parity of esteem agenda. And any new issue that comes up in medicine or comes up in society generally, I think it's really important to think, what's the mental health angle on this? How will this affect our patients? And what are the things that we need to watch out for and to argue for to make sure that there is parity of esteem and that our patients get a good deal? So it's a fabulous session. We've got great speakers, and really honoured to have you all here. So thank you very much. And of course, the first session really is a reflection on severe mental illness and the European COVID-19 vaccination strategy. And this first session is really based largely on a 2021 Lancet paper that really outlined what was happening. And we're going to hear more about that and the response of various nations. So we've got two fabulous speakers, Dr. Livia de Picca, psychiatrist and postdoc at the University of Antwerp and president-elect of the Belgian College of Neuropsychopharmacology and Biological Psychiatry. Congratulations on that, and best of luck with that leadership position. And following her, we've got Marisa Casanova Diaz, who's already introduced herself, and fantastic to have you, Marisa, as president of the UEMS psychiatry section. So over to you.
Hey, so thank you very much. In this presentation, I'll start by introducing our work on severe mental illness and COVID-19 vaccination strategies, and I'll also be covering policy implications, and then I'll be followed by my colleague, Dr. Livia de Picca, who's going to focus on the scientific underpinnings. So we've published this work in The Lancet shortly after the COVID-19 vaccine was made available. And we have been shortlisted for an award because of the impact that this work had in helping changing policies across Europe. And it's important to note that this was a work done by a group of individuals, but also a strong collaboration between the major European psychiatric associations. Our section of psychiatry of UEMS, Gaiman Europe, and we'll have Hilke speaking later on today, EUFEMI, which represents associations of families, the European College of Neuropsychopharmacology, and EPA. Topic, and this was the answer that I got, that people with severe mental illness should be prioritized for vaccination, that they should be included in the same priority group as other at-risk populations, and that we must ensure they have access to the vaccine, to information, and to support. But why is this important? Well, it's important because 2 years ago, when the vaccine came up, reality was very different. And this is what we found in our study, where we systematically analyzed all the vaccination programs across 20 European countries. And we found that only 4 of them were giving priority to people with severe mental illness. And perhaps even more striking is that the great majority of them didn't even mention people with severe mental illness in their vaccination plans. So reflecting on that, we felt that we're talking really about a lack of equity and parity, because we knew that this group was prone to have, they're more likely to have infections, and they were more likely to have adverse outcomes. So really, why were they not being prioritized or put in the same categories as other at-risk groups? And reflecting on that, and of course, this is complex and there's several factors that may play a role here, but we realized that the original research was not taking into consideration this group. And because, we don't know what we don't measure, we didn't have that information, it didn't go into the reviews, and therefore, when it comes to making policy, it wasn't taken into account. So that's why we felt it was important to come up with policy recommendations. And this is what we recommended, that this group should be prioritized, that we should involve patients and families in developing the vaccination plans, and the importance of education. And through this advocacy work, and which received extensive media attention across Europe, we were able to help change the vaccination plans across these European countries and change the findings that we had. Further work has been done by our group and other groups, further confirming that really, so through systematic reviews and meta-analysis, that this specific group is at higher risk of adverse outcomes. And those outcomes are different for the different diagnoses, with people with mood disorders and psychotic disorders being more adversely affected. And this is more recent work that we've published just a few months ago. Again, looking at the evidence, this was through an umbrella review where we looked at all the evidence that has been published so far, and again came to the same conclusions, that people with severe mental illness are at a higher risk of adverse outcomes. And therefore, we came up with recommendations, policy recommendations, that cover vaccination and testing, treatment, psychiatric care, psychopharmacological treatments, and research priorities. And I invite you to have a look at it in your own time, and please come back to us if you have any questions. And to finish, I asked again OpenAI about the future. And this is what it told us, that the pandemic has highlighted the importance of addressing the needs of individuals with severe mental illness and disparities. And we can't agree more with that. So the take-home messages from this work is that collaboration is key, advocacy works, and we need to follow the science. And on that note, I'm going to thank you, and I'm going to hand over to my colleague, Livia.
You're on mute, Livia. Your screen says you're off mute, but oh yes, we can hear you now. Can hear you loud and clear. Thank you.
Blah, blah, blah. Okay. Can I get feedback if you can hear me now?
Yes, loud and clear.
Okay, thank you very much. So thank you, Marisa, for this excellent introduction and reflection of indeed collaborative work that spans the whole of 2 years of the pandemic. And I'd be happy to go a little bit further in depth about the scientific background of the work that we did, and also what happened, or the more evidence that has been compiled since then. Voilà. So in this presentation, I'll be talking about COVID-19 risks and mental illness, which you've already heard in the previous talk, that there is indeed, and even the AI knows about this by now, an increased risk of COVID-19 infection, but also of COVID-19 adverse outcomes in people with mental illness. These are my conflicts of interest. And this is something that we've known already quite early in the pandemic, already in the autumn of 2020. This was the first year of the pandemic. And so despite definitely the original studies looking at predictors of COVID-19 adverse outcomes did not include mental illness as a variable of interest. There were individual separate reports, mostly by psychiatric research groups, showing increased risks of COVID-19 in people with psychiatric diagnosis. For instance, this one from Chinese data published early 2020. And so taking all of that preliminary work into account, we did feel very strongly that there was a need to campaign for priority vaccination of patients with severe mental illness, because looking at the effect sizes of mortality, risk of mortality following a COVID-19 infection, if we compared what we knew at that time about risks for people with severe mental illness compared to other kinds of comorbidities that had been recognized and identified at the time as indeed risk factors that would make these people eligible for priority vaccination, the risks of people with severe mental illness were actually as high or higher than those of the other conditions. But that was not at all reflected at that time in the different vaccination plans that we have reviewed. And you can see here the list of countries. And so wherever there is a mention of Tier 1 or Tier 2, this means that a country would have given priority at some level to this specific condition. And you can see that, for instance, here for chronic pulmonary diseases, most of the countries would have given priority vaccination to people with that condition, whereas the risk of mortality with that condition was lower than for people with severe mental illness. And we also confirmed this increased risk in our own research with a meta-analysis on the COVID-19 outcomes, both mortality, hospitalization, and ICU admission. And we saw across the board an increased risk of nearly twofold for any psychiatric disorder, which was even higher in the patients with severe mental illness. So it's really this group of vulnerable people with psychotic disorders and severe mood disorders that were affected the most by the adverse outcomes following COVID-19 infection. And I think what was also quite striking and difficult to understand is that the people with other types of mental disorders, so not severe mental illness conditions, were at a much higher risk of hospitalization compared to those with severe mental illness, whereas the mortality risks, it was the opposite. So at that time, we were suspicious that maybe there could also be an issue of people not having access to hospitalization as much, or having difficulty accessing care for an infection. That was something that we did take into account in our further work. Which then indeed 1 year later, we reviewed the evidence again for what was known at that time about infection, hospitalization, and mortality. So there is limited evidence of a high risk of COVID-19 infection in mental disorders, and that is in particular for schizophrenia, mood, anxiety, and alcohol-related disorders. There is a higher risk of COVID-19 hospitalization for people with psychiatric disorders, except for psychotic disorders. There is no increased risk of ICU admission, but highly robust evidence for increased mortality, and again, in particular for psychotic and mood disorders. So here again, across the board, our own research and other groups' research, we see increased mortality in people with psychotic disorders, but these are also the only group not to have an increased hospitalization risk. So then we come back to the causes. Why is this? Why do we see this increased mortality? And I'm quite embarrassed after 2 years of talking about this that my true answer is I still don't know. We still don't know. Maybe I should ask ChatGPT to give me some clues. And of course, we do have a hypothesis about this, but the true answer still remains to be found. So what we know is, yes, there is an increased infection rate, and we've seen that also in our own research. We've recently looked at COVID antibodies in a cohort of patients from our own hospital and another hospital in Paris. People were sampled in the first quarter of 2021. So this was just before a vaccination campaign. And 71% of all our inpatients with severe mental illness had COVID antibodies, despite none of them having ever had a clinical diagnosis of COVID or ever having had a positive PCR test. So these were hidden infections, hidden exposure to COVID-19 that was much higher than what we have seen in the caregivers working in those same hospitals at the same time, though they only had a 27% COVID antibodies. So for sure, many, many more patients than we are aware of and they are aware of have been exposed to COVID-19. And this could obviously lead to adverse outcomes, but that does not fully explain the increased mortality odds ratios that we've observed, because those are odds ratios comparing only outcomes in people who have been infected with and without psychiatric diagnosis. So perhaps it's related to a higher prevalence of comorbid risk conditions. This is something that we hear many, many times. People with psychotic disorders are more likely to also have cardiovascular problems. They're more likely to smoke or have obesity and other kinds of risk factors that we know are associated with COVID-19. But again, obviously, in most research that has been accounted for. So we have calculated also adjusted odds ratios, adjusted for all of these factors that we know are associated with adverse COVID-19 outcomes. And even if, yes, the absolute risk is lower after accounting for these other factors, there is still a mortality gap. So again, maybe it is this reduced access to care, and there is conflicting evidence about this. It does seem to be that it could have been the case in some countries, but not necessarily all countries, which obviously makes it very difficult to say something across the board. And I would really like to see more evidence coming out to make any kind of solid conclusions. But one of the findings that we did see in our meta-analysis was that we only found a higher mortality and higher ICU admission among patients who were not hospitalized at baseline. So basically, if your COVID diagnosis or PCR positive test happened at a time when you were already in a hospital setting, either a psychiatric hospital or a general hospital, then you would not have had an increased mortality odds ratio if you also had a psychiatric disorder. Biological factors of the illness. I work in immunopsychiatry. We study the underlying immune aberrations in people with mental health conditions. So yes, of course, it does not come as a surprise to me that we see, and this has been confirmed in recent research, a deficient and aberrant immune response in patients with pre-existent mental conditions and severe mental illness, both following a COVID-19 infection, but also following the vaccine. We see a different response in these individuals. And there is also pre-existing evidence from before the pandemic showing accelerated aging of immune cells. So you could basically think of severe mental illness affecting people's risk similarly in the way that age also does. So we know that age is one of the major risk factors affecting COVID-19 adverse outcomes. And if severe mental illness as a condition causes accelerated aging of your immune cells, then it would make sense that this also increases your COVID-19 risks. And then finally, there's been a lot of debate about the impact of psychopharmacological drugs. It's a very, very difficult question to study, because how do you disentangle the effects of the illness and the treatment that is being used to treat the illness from each other without being able to test this in a randomized controlled experiment? So in our own work, and also other meta-analyses have shown the same, we have seen a very highly increased risk of COVID-19 mortality with antipsychotics, and this is both in raw but also in adjusted measures, and that has been confirmed time and again. But we have to take into account this is all patients on antipsychotics regardless of the diagnosis. So obviously there's going to be a confounding by indication going on here. So what we really need is studies looking at people with the same diagnosis, both medicated and unmedicated. And to my knowledge, there is also only one such study that has been completed by Kathleen Nemani in New York. She has done a cohort study of almost 2,000 patients with severe mental illness, longitudinal follow-up. Almost half of those patients were infected with COVID-19 at one point, and then they compared patients who were treated with different kinds of medications, showing on the whole no increased risk of infection or mortality in medicated patients, medicated with antipsychotics, and in particular, and I think this is very important, also no increased risk with clozapine, despite earlier warnings that were published, case reports that have been published of maybe risks related with clozapine and neutropenia that can happen with clozapine. That was not confirmed in this cohort study. For mood stabilizers, and this is really very preliminary evidence, so Kathleen Nemani did show some evidence of increased odds of infection with valproate, and we have shown in the Trinetics database decreased odds of infection with lithium. So this was comparing people with therapeutic lithium levels compared to people with subtherapeutic or low lithium levels, showing that those with the therapeutic lithium levels had seem to have a protective effect against future COVID-19 infection. Of course, again, we don't know what this means. It's electronic health records data. There could be tons of confounders, even if we try to account for all of them. It's very much possible that this is a compliance effect and that people with therapeutic lithium levels just had better compliance, or they were being followed up more closely by healthcare workers, and that's why they might have been more protected. For antidepressants, these have been quite a hype throughout the pandemic. So there have been multiple reports of a possible protective effect. I have yet to see this confirmed in a good RCT. Well, at least for the people who already had pre-existent mental health conditions and are on antidepressants, we did not see an increased risk of severe outcomes. So it does appear for the people with mental health conditions that using antidepressants does not influence your risk. There are two small placebo randomized controlled trials that I'm aware of with fluvoxamine, showing positive effects against future hospitalization and progression to severe disease, but these were done in people without mental health conditions, so just in community people with a COVID-19 infection, which I think is something different from what we are talking about. So to conclude, and as far as all the evidence is concerned, we still see the same thing as what we saw in the first year of the pandemic. Psychotic disorders, and in particular schizophrenia, is a gigantic risk factor for COVID-19 death, second only to age, as you can see here. And unfortunately, this has not changed following the vaccination campaign. These are data from the UK, showing excess mortality in people with severe mental illness, and in particular schizophrenia here in purple, even after we've started vaccinating the population. So this is a problem, and it's even a bigger problem if you realize that we are seeing lower vaccination rates in people with severe mental illness. So despite them being prioritized or given early access to vaccines, they're not getting the vaccine as much as they should be, taking into account the risk profile. And then there's been a debate if this is related to people not being willing to be vaccinated, or if they're unable to be vaccinated because of certain barriers that they might encounter. Even if they're vaccinated, they also have a lower antibody response. We have tried to look into this ourselves, following up patients before and after vaccination with blood samples. We did not really see a difference in antibody levels early on after the vaccination, but another group has demonstrated that in the long term, so this is between 3 and 6 months after the vaccination, having a psychiatric diagnosis is a predictor of lower antibody levels in the longer term. And also there's been evidence of increased risks of breakthrough infections after vaccination, which basically is the real world evidence that this lower antibody response does translate also to being not as protected as people should be. And then to make matters worse, and this is unfortunately still unpublished data, but there is also evidence showing that even if people are fully vaccinated, there is still a mortality gap. So even among double vaccinated, triple vaccinated people with schizophrenia and also in bipolar disorder, there is still an increased mortality compared to people who are vaccinated without the diagnosis. Just very quickly about the vaccine hesitancy and equity debate, because I think this is really important. I was at a conference about a year ago, and there was another researcher there from Israel who made a statement that there are no barriers against vaccination in our country. And I think he really believed that that was the case, which made me wonder if maybe the same problem is happening with policymakers, where they really believe that they're doing everything they can to make vaccines available to everyone. And so they might not understand that people with certain mental health conditions still experience barriers because the setup of the vaccinations and the whole logistics of it are not designed for them. They're designed for the general public, and they might actually need something else. So despite the increased risk, we do see lower vaccination rates. It's not the same in all countries. Here in Belgium, we have shown that if you make a targeted vaccination program specifically for individuals with severe mental illness, then you can get good vaccination rates, just as much as general population. But I realize that there might be maybe also cultural factors affecting these outcomes. But in any case, it's clear that we need proactive approaches to ensure vaccination equity, removing any and all barriers, logistical barriers, financial barriers, people having to move somewhere, go somewhere, take public transport could be a barrier, people not being able to or not feeling comfortable getting a vaccine by someone that they're not familiar with and preferring to get vaccinated by a healthcare worker that they already know might be an important aspect. Involving the existing care network of the patients is therefore hugely important. And I think also adjusting the vaccination schedule based on what we know now about the deficient response. Maybe they need to be vaccinated more frequently and need to get different types of booster doses. There is still a lot of questions here, and I don't see enough work addressing that.
Livia,
And that goes.
I think we need to wrap up there, so we're running over a little bit.
This is the last one, so thank you. And I was just going to finish saying that this is going beyond COVID. Obviously, there is other vaccine preventable diseases where we see the same situation. So all the work that we can do to understand better why people are not getting vaccinated as much or have a lower response to vaccination, that will also help prevent other kinds of infections in these patients. Voilà, and this was my take home. So we've covered a high hidden exposure of COVID-19, increased risks, vaccine inequity, and a need for research on infections in patients with mental disorders. Thank you very much. And I welcome questions if we still have time.
Livia, thank you so much. That was such a comprehensive presentation, and also Marissa too, and fantastic the work that you did in mobilizing the forces really to do the very best for our patients. I think we will have to move on. Rachel makes a good point in the Q&A about obviously vaccination rates are important, but actually more space in the areas where we look after our patients is important in order to reduce transmission rates. So keep the Q&As coming. I know, Olivia, you have to go. Thank you so much. If we've got any specific questions for you, we'll pass them on. So thank you so much to Marissa and Olivia. So let's move on to a broader topic now about how COVID-19 shaped mental health from infection to pandemic effects. And we've got Brenda Pennings, a professor of psychiatric epidemiology at the Department of Psychiatry of Amsterdam, UMC. And this is a presentation based on a 2022 article published in Nature Medicine. So Brenda, over to you.
Thank you very much for the introduction to indeed talk a little bit more broadly about how COVID-19 shaped mental health. And actually my talk is completely based on a paper we published a few months ago in Nature Medicine. So for those who want to know more, because I only have a few minutes to talk about this, I really would advise you to read this paper. But I will highlight some of the main findings and topics that we wrote about in this paper. And as Adrian indeed already nicely introduced this, we're talking about the impact of both the pandemic as well as the infection on mental health. And I don't know about the UK, but I'm quite sure it's not very different from the Netherlands. But when we got into the COVID-19 pandemic, immediately there were all kinds of news reports. And I just cite here a few Dutch news reports, not that I expect that people are able to read them, but these news reports are very diverse. In the beginning, you know, there were lots of articles in the newspapers being worried about the impact that COVID could have on people with psychiatric symptoms, on normal, healthy people, and the impact on their mental health. And the expected direction of the associations and the impact was really completely going from beneficial to unfavorable. And I'm sure that in many countries, you can point towards those kind of news articles. So there was lots of speculation on the impact of COVID pandemic on mental health. Also, if you look in PubMed and look at the academic literature on what has been reported of the impact and the relationship between COVID-19 and mental health, it's quite overwhelming what you find. If you just type in the hits of COVID-19 and mental health, you have more than 40,000 papers. Lots of these papers are, you know, not per se very strong evidence-based studies. I have to say that lots of, especially in the beginning of the pandemic, there were lots of quick studies based on convenience samples with rather unclear generalizability, lots of surveys that, you know, used online tools to quickly survey the mental health status of the population. And, you know, it was completely unclear how the findings should be interpreted and how we really could compare it to the pre-COVID situation without having a clear reference. So this is kind of an overwhelming literature. And what we tried to do in the Nature Medicine paper is really focus on some of the good meta-analytic studies out there that have really used a pre-COVID reference, for instance, using existing cohorts where they already have measured mental health before COVID. And then those surveys went on to measure mental health during the first year of the pandemic, for instance. Fortunately, there are also some of those what I call good studies, where we really can learn more about what the true impact of the COVID pandemic is on mental health of the general population. And this table clearly shows that, for instance, for general mental health problems, there are over 61 studies involving more than 50,000 individuals from the general population that have used a pre-during COVID pandemic comparison and looked at self-reported instruments of mental health symptoms. And when you summarize, and there have been several meta-analysis and pooled analysis done, if you summarize the findings of those studies, these studies all point towards indeed a modest increase in symptom levels in the first year of the COVID pandemic. So these studies compared self-reported symptom reports during the first year of the COVID pandemic with prior reports in the same people before COVID. Even if you look at depressive symptoms and anxiety symptoms, you do see increased pooled effect sizes. But again, I have to highlight that the increased effect sizes are really quite modest. We're talking about effect sizes of 0.22 for depressive symptoms, ranging to 0.27 for loneliness, which is actually the highest pooled effect size that has been reported on. So again, there's some evidence for modest increase in symptom reportings of mental health at the general population. The World Health Organization has estimated also whether these kind of reports may result in an increased incidence of disorders. However, there are only a few studies that truly have measured the incidence of psychiatric conditions. There are 3 or 4 good population-based studies that during the first year of the pandemic have looked at the disorder prevalence and have been able to compare it to prior estimates using same instruments. And these studies actually all point out that there is no measurable increased incidence of psychiatric conditions in the first year of the COVID pandemic. There is also a large-scale meta-analysis of suicides reports in the various countries across the globe, because several countries have been able to look systematically at suicide modality. And so far, there has not been any evidence of an increase in suicide rates during the first year of the COVID pandemic. What I want to emphasize is that these are all population-based estimates and reports. I think it's clear that when you look within some of these studies, that they have been able to identify higher risk groups where effect sizes of the impact of the COVID pandemic on mental health symptoms is higher. And I think there is very strong and consistent evidence that the pandemic has hit certain groups harder than others. The first risk group are women. A second clear risk group are people from minority groups, like people from different ethnic backgrounds. And a very other strong risk group for higher impact of the COVID pandemic are older children and adolescents and young adults. So it's clear that there are certain vulnerability groups, and actually several of these vulnerability groups are already groups that were higher at risk for mental health issues, and they seem to be hit harder by the COVID pandemic as well, so increasing their already higher vulnerability. So what about persons with mental disorders? This is also a question that has been examined in quite some of these conducted study. And actually the evidence for the impacts of the COVID pandemic in people with mental disorders on an increase of mental health symptom reports is quite unclear. And this is a picture that comes from a study that we run, where we had large cohorts of people with depressive and anxiety disorders, as well as healthy controls that we already followed before COVID in many waves. And the first block that you see on all of these lines are the pre-COVID levels that we found in patients with depression and anxiety disorders. The red line, the blue line are the healthy controls. And you see their pre-COVID reports as the first block on these lines. The subsequent waves of data were collected during the first year of the COVID pandemic. And as you can see, depressive symptoms, especially in the healthy controls, went up a little bit and then kind of stabilized during the first year of the pandemic, did not return back to normal levels. The same finding, a little bit less clear, was there for anxiety symptoms, again, with the healthy controls going up a little bit and then stabilizing during the first year of the pandemic. The fear of COVID really follows very closely in both patients and healthy control groups, follows the lines of the COVID infection rates, with the fear going up when the infection rates were higher. And loneliness, again, shows an increase, especially in the healthy controls, which actually goes up a little bit over time during the first pandemic year. Lines are quite parallel between patients and healthy controls. We are not showing that relatively patients have a larger impact of the COVID pandemic than healthy controls. But also very clearly from this picture is that already at the beginning and already before COVID, patients, are at worse and way worse mental health than healthy controls. And this is going on during COVID pandemic too. So we do not find a relative stronger impact of the COVID pandemic on mental health patients, but we obviously do see that they are highly vulnerable just because of their poor mental health status before and during the COVID pandemic.
Brenda, we need to wrap up fairly soon so we can have time for the last two speakers. Thank you.
Yes. The topic of whether COVID infection itself has impact on mental health, we also report on, and this is really referring to the prevalence of acute and post-acute COVID-19 symptoms. And we do report on the literature there as well, clearly indicating that also in the post-acute phase of COVID infection and COVID disease, there is really evidence of increased risk of mental health disorders and mental health symptoms that we believe is really relevant for the field to be aware of. So if you just think about these findings and think about the impact that both pandemic as well as infection has on mental health, I think there are a few key findings and lessons learned that we pointed out in this paper, and I will quickly summarize them and then refer to the paper for more details. The first is actually in line with the prior talk by Livia to really make attention for the fact that mental health should be given equal priority during these pandemic times as compared to physical health, which is not always the case. It always kind of gets after the fact. Second, in the paper, we also make a plea that good communication and trust is essential for mental health. There was a lot of polarization in news reports, which is really giving possibilities for unfavorable effects on mental health. Also, as I indicated, rapid research should be collaborative and high quality. We should learn from the experience that we had that lots of studies were not always very useful, and we really need to zoom in immediately on standardized, well-controlled studies that are well-powered. We should also not neglect the long-term mental health effects. Because we know quite a lot about the first months and maybe even the first year, but some of these effects can be really long-lasting. Think about the impact on mental health due to work and income differences and changes. We should pay attention to the mental health consequences of infectious diseases in general, and also obviously of COVID-19 and long COVID. And finally, we should prepare mental health care infrastructure for pandemic times. It's clear that there were quite low levels of technical literacy among the clinicians, and we really should be better prepared so that we can do rapid upscaling of treatment infrastructure also for vulnerable groups in the future. And with that, I would like to highlight again, more details can be found in this paper, and I'm happy to take questions in the later question and answer session.
Well, thank you so much, Brenda. That's really very comprehensive and incredibly interesting. And hopefully we'll have 5 minutes for questions at the end of the session. We now need to move straight on to our next speaker. So we've got 10 minutes for the next speaker and 10 for the one after that. So we're going to hear from no other person than Professor Norman Sartorius, former president of the WPA and former director of the World Health Organization Division of Mental Health. And Norman, it's a real honor to have you with us, described it on your Wikipedia page as being a living legend. So we're so lucky to have you with us, and you're going to tell us a bit about the future of psychiatry after COVID-19 and say if we can keep this till 1 o'clock, move on to our final speaker, and then time for a few Q&A. So over to you, Norman.
Thank you very much. Thank you for inviting me, and thank you for your kind words. I'm to speak about psychiatry in Europe after COVID, and this is an easy thing because it's very difficult to believe that the many predictions that have been made, some of them will undoubtedly be true. Now, I think that what we have seen is for any epidemic and any pandemic, we can expect that there will be some foreseeable consequence of a pandemic. For example, we can expect that people who have comorbid diseases, be it mental or physical or other disadvantages such as poverty or malnutrition, etc., that these people will have a higher mortality. We can also expect in a situation in which the crowded habitation, which is very present among the poor, will in fact be increased, that there will be an increased rate of intrafamiliar violence, as it happened in a number of countries. We can also expect an increased consumption of alcohol, a loss of employment in some countries. And in fact, for example, in India, the loss of employment on the west coast of India created a movement towards the inside of the country of several million people. Most of them came back home from where they ran away before because there was not enough food for them. They came back, and there was a huge number of people who died of hunger because there was no hunger, and there was no jobs, and there was no money, and there was nothing. We can also expect that public health authorities will in general be unprepared for situations which are extraordinary, and many of them will in fact do bad things or not do anything at the time when they should have done it. And then we often have to forget, but we should remember that there are a number of delayed health damages that will happen. For example, the fact that for the 3 years there was no testing for breast cancer, it is very likely that a number of people who will be affected by the breast cancer at a too late stage to intervene usefully will also lead to a higher mortality from that disease. Similarly, a number of people with cardiovascular disease could not get to the doctor during their time. Care was interrupted in many ways. Many of the childhood diseases which have been until now successfully prevented by vaccination will not have been prevented because there was a stop in most countries for nearly 2 years of any vaccination against the common childhood diseases. Now, these are all things that we can expect. But there was also, in this particular instance, some unexpected consequences. For example, there was, in fact, during the pandemic, a decrease in child mortality in a number of countries. Various people have been giving various hypotheses why this could be so. One of them, perhaps, has been that there was less traffic and therefore less traffic accidents. Another one was that perhaps parents were generally more present and looked after children a little bit more than they can if they had to go to work. We have also seen a curious variation of suicide rates. In some countries, suicide rates went down, for example, in Canada. In other countries, it went sharply up. And we are not quite sure what the relationship is between suicide rates and the pandemic such as this one. The stigma in the health system, of course, we can expect it. And we have seen it quite clearly that I think a number of signs of stigma have also been presented in the previous talks today. But there has been a number of places where mentally ill people have been thrown out hospitals to make place for people with coronavirus infections. And people have also not been given treatment and died because of that, very much a consequence of stigma. It was an interesting fact was that has been described as the discovery of family members. Many parents, particularly males, fathers, have in fact suddenly discovered that they have children because they were forced to spend time with them. And they discovered that these children are charming, delightful, and They spend time with them, which was not the case before. In fact, there is a number of photographs that have been made of a large number of males looking after small children, which has not been available before pandemic. Unfortunately, for a variety of reasons, there has also been an increase of adolescent pregnancies as a consequence of the pandemic. Jobs have become free. Nobody knows where the people went, and those jobs, nobody has been taking them. There has been, I think, somewhat disappointment in the usefulness of telemedicine, which could have perhaps otherwise done something useful in such a situation where people were forced to be at home, but it did not. I think we have not yet developed the simple ways of applying it sufficiently to make it possible. And then there was a surprising fact as well, that a very high proportion of people working in the health field, nurses, for example, have refused to accept vaccination, which on one hand didn't give a good name to the vaccination, and on the other hand, increased their vulnerability and the chances that they themselves will suffer greater consequences, more unpleasant consequences of the pandemic. In psychiatry, well, I think as if I mentioned earlier, stigma of mental illness was expressed in health facilities where the psychiatric departments have been given least care and in many instances have suffered quite badly. We have also heard that people with mental illness have significantly more often died. For example, the studies that have been done in the American system of hospitalized mental ill patients, some of the work that has been presented just now by the colleagues who spoke before me also speak that there was a mortality for severely mentally ill people who, of course, not only are severely mentally ill, but very often have comorbid disorders and are therefore at high risk of yet another disorder which hits them. The use of telepsychiatry in medicine, in psychiatry, no, have not really given us a great answer. And then we have seen an increased prevalence of depression and anxiety with an unfortunate confusion between being depressed because you lost your job, because you lost your parents or something, and being depressed as having a mental disorder, depression, which can be treated by mental illness. And I think that the distinction between depressed by external circumstances and having a depressive illness has not been sufficiently well qualified nor studied in this instance. Psychotherapies worldwide have been interrupted. Whether this will have a significant impact on that, nobody has yet studied. It would be nice to know what kind of a consequence that will have. Now, what can we learn from the COVID in psychiatry for tomorrow for Europe? Firstly, I think we have to think of ways of optimizing telepsychiatry and making it a part of the postgraduate training, that people learn how to use telepsychiatry, how to establish links which can be helpful to them, advisory roles, etc. We should also think of introducing a significant amount of disaster preparedness training. We have some disaster preparedness for natural disaster, not for psychiatry, but for general medicine. But it would be helpful to think of expanding the thinking about this disaster preparedness also to psychiatric services, to think what to do with a larger number of people who will also have a physical illness, etc., because it is undoubtedly true that further epidemics and pandemics will hit us, if for no other reason than for the reason of deforestation, which has forced a huge number of animals that were previously living in forests, like bats, for example, to come to town and bring with them not only themselves, but also their diseases. I think that we should also gradually think about improving the training of the general practitioners and the general health personnel to deal with the situational anxiety and depression, which they will undoubtedly have to face in instances of an epidemic or a pandemic. And then equally so, the wonderful effects that the self-help manuals, for example, the Australian one, had for learning how to cope with problems, including problems of infectious disease, might also be a useful thing to do. We shall have to think of ways of what we can do with people who do not want to be vaccinated, because there will be some of them, and maybe many of them again, in the next epidemic. We have to think of ways of dealing with long COVID, which is that undoubtedly, like in the epidemics of 1904, 1906, the St. Petersburg flu, and then the Spanish flu, all of them had long-term, particularly neurological effects. And we have to think of ways in which we have to deal with those, because they will undoubtedly become apparent very soon in larger numbers. We should think of ways in which we equip psychiatric facilities with something that will help them to deal with comorbid diseases which appear in these facilities. There are still hospitals in the world in which a psychiatric hospital is disallowed to have in its pharmacy any medication for physical illness. I think that that is an example of the division which has existed, but hospitals are places where all diseases should in fact be handled better than outside of them. And I think that that is something that we should keep in mind. We should search ways to prevent infodemics, which have been as harmful as they can be. I think Dr. Pennings has mentioned some of the reactions, and there are other examples as well of the ways in which the information that reached the public, etc., has done bad things. And we should think of ways in which we can provide care if suddenly there is a disappearance of health personnel. We have to think of ways in which the public in general learns how to deal with such disorders. So in many ways, I think the COVID pandemic was a rehearsal for more deadly epidemics that will come without any doubt. And I think that we should use the knowledge which we have gained to make ourselves better prepared for the next one. And I think next, we should also remember that in addition to planning how to respond to pandemic conditions in psychiatry, we should also learn how to think about knowledge that we have already gained during the COVID in planning for our future training of psychiatrists and all other personnel. I think the pandemic was a powerful confirmation of the importance of strengthening communication, of help to one another, of bringing people and maintaining the contact. And I think that the protection and the strengthening of these links between people, the willingness to help each other, are a true priority for humankind's survival, not only for those who are unwell. So I think that it's not easy to foresee what will be the psychiatry after COVID, but there are many lessons that we have learned from it. And I think we would be well advised to think about these lessons and use them in training, in the organization of services, and in talking with people who are affected by mental illness and their families. Thank you.
Norman, thank you so much for bringing all your experience and wisdom to this. It's really important that we learn the lessons, and some of them may appear to be fairly obvious and some of them aren't. We need to look out for both of those things. So let's move on to our final presentation, and really pleased that we've got the patient's perspective on COVID based on the Gamian's COVID-19 surveys. And we have Hilkka Karkkainen, past president of the Global Alliance of Mental Illness Advocacy Networks in Europe. And Hilkka, delighted to have you with us. Thank you for joining us, and really important to hear the patient's perspective. So over to you. You have your full 10 minutes. We'll just have a couple of minutes for questions. So over to you.
Okay, thank you.
You've gone on to mute. We could hear you right at the beginning, Hilkka, but
Oh, can you hear me now?
that's fine. Thank you very much.
Okay. Oh, okay. So thank you. I try to be very brief because I know we are over time already. To start with, I'm not concentrating in this presentation only for those with severe mental health condition, but for people with all kind of mental health conditions. Next slide, please. So Gamian Europe is a patient-driven pan-European organization representing the interest of more than 60 organizations from Europe and beyond. And our activities are related to advocacy and EU policy, information and education, awareness raising and addressing stigma, partnership and capacity building. Next, please. Well, the first survey we carried out in autumn 2020, and it aimed to find out the initial impact of the pandemic on people with pre-existing mental health conditions, asking about changes to their mental and physical health, whether they had contracted the virus, any difficulties with accessing healthcare, and who gave them the most support. And it was translated to 13 languages and sent to individuals via Camion Europe member organizations. And 551 people responded to the survey, all of them with pre-existing mental health conditions. Next, please. So half of our respondents experienced a deterioration in their mental health. And much of this worsening of mental health appears to be the consequence of the lockdown measures and concerns about contracting the virus magnified the stress felt by respondents, and also the continuous media coverage of the number of deaths and hospital admissions due to this virus has perhaps also played a large part in heightening respondents' stress and anxiety. And uncertainty about the future was another source of distress. Next slide, please. The majority of respondents experienced no change in receiving their usual mental health care and were able to access mental health services when required. And mental health services adapted quickly to ensure patients were able to remain in contact with their healthcare professionals. Some positive aspect was that some respondents found lockdown gave them more time to relax and took them away from usual daily pressures. This might also explain why half of respondents experienced no decline in their mental health. Next, please. The second survey was carried out in cooperation with the European Psychiatric Association between October 2021 and February 2022. And the purpose of this survey was to chart the impact of the pandemic on mental health services, the changes in service delivery, pressures arising from an increase in demand, and whether these affected the mental health of patients and clinicians. The report presents the findings of excuse me, 369 respondents. 63 of respondents defined themselves as patients, and 22% of respondents were mental health professionals. And interestingly, 7% considered themselves as both a mental health professional and someone with mental health problems. And 11% of patients were diagnosed during the COVID-19 pandemic. And 80% were new respondents. Next slide, please. The impact of the pandemic since the first survey, carried out more than 1 year later, was still being felt by many. Worsening mental health was reported by a third of respondents, and for a small minority, their mental health condition was reported to be because of the pandemic. And many patients were able to access mental health services, and medication was the most accessible. Talking therapy and seeing their usual mental health professional was limited for some respondents. And delivering outpatient appointments online or by phone appears to have become the norm. And 12 months since the outbreak of COVID-19, nearly half of patient respondents had their outpatient appointments this way. Next slide, please. Fewer and shorter appointments also seem to be the norm for some, and waiting longer to see a mental health professional. Although mental health services issues were well before the pandemic, the lack of resources had greatly intensified since. And 69 respondents reported that their their treatment needs had been met. This provides some testament to staff going the extra mile by working longer hours to ensure patients' needs and the increased demand for services were being addressed as far as possible. Almost a quarter of patients reported their needs were not being met. The provision of new staff, extra resources and/or funding was noted only by few professionals. Also concerning is the negative impact of professionals' own mental health with the pressure to deliver more services, some of whom were diagnosed with mental health problems and many more received treatment and counseling. This in turn affected their ability to deliver services. Next, please. So what could have made things better? According to respondents, the government could have done more to support mental health professionals and improve mental health services, and more consistently in terms of COVID-19 rules, easier access to specialist mental health services, and tackling the deepening crisis within mental health services generally. And access to services was also that it could have been better by lowering thresholds and that act independently of insurance or clinics where a trained person could connect to you to the right specialist and therapists. Next, please. So to conclude, our findings, as with other surveys, show that still much remains to be done and to health of patients and professionals alike, with governments across Europe while governments across Europe responded to the pandemic and to some extent acknowledged its impact on mental health, investments to address mental health needs remain more important than ever. This is a challenge for many governments, but cannot be sidelined. Respondents listed a number of promising best practices operating during the pandemic and the scaling up many such practices. Particularly peer support programs offer an important way forward towards meeting the ever-increasing demand on mental health services. You can read these recommendations on our website and the full reports. You can also click from these QR codes. Next, please. Thank you very much. I'm ready to take questions if you have any. Thank you.
Well, thank you so much, Hilke, and we must all remember that everything we do is about our patients. That's who we exist for, and they have to be the focus for everything that we do. We are really coming towards the end of the session now, and wanted to thank Rachel for putting some comments in the chat, drawing attention to the lack of parity, for instance, in relation to infection control, one rule for physical health, one rule for mental health, the importance of liaison services. But Rachel also raises the issue whether we should concentrate on specific groups, for example, for research, and welcome your comments to that. I could probably just go to each of you just one by one. Unfortunately, I can't, the system won't allow me to start my video. So I don't know if somebody could start it for me. That's great, thank you. I'm just going to go to each of you and say a quick comment about, are there specific groups we should focus on, but also people watching this, practicing psychiatrists, other people working in mental health services. What's the take-home message that you would like people to take away from this really very historic session, I think, that we've just had? Marissa, do you want to start, and then we'll move through very briefly.
Sorry, my internet connection froze, and I didn't catch the question.
So the take-home message, what one thing, for example, that you want somebody to go away and do, for example, in the next week, in relation to what they've heard today, but do you think there are specific groups that we should focus on, for example, children and young people? Marissa, I don't know if you're, we can see
So I'll
you.
tell you in terms of what people could do, I think what we've come up as a group in terms of policy implications from our most recent work, so the last paper that I presented, I think it would be interesting if everyone could have a read through, because that's already a summary of all the work that we've done with patients and families, and see how that works in their own environments where they practice, and see how that refers to their own environment and what they can do as a clinician. You don't need to be in a high policy body. You as a clinician have the power to make the change.
Thank you, Marissa. Brenda.
Yeah, so I highlighted already the impact of the pandemic overall for young adults and adolescents. So I think this is really something that deserves attention in future pandemics, to really see how we can make certain that this vulnerable group is not the group that is being hit hardest. And in addition, and this refers also to the other comment that I saw by Rachel, is the connection between the somatic discipline and the mental health care, which I think also in the case of long COVID and people with lots of PACS conditions, I mean, they're still suffering, a lot of people with mental health consequences of COVID disease and COVID infection that is really strenuous, long-lasting, where we really need to have a better integration on what is going on exactly and how can we treat these people at the best manner. So really by connecting the somatic and mental health fields more carefully in those cases.
Thanks very much, Brenda. Norman. You're on mute, Norman, sorry.
Well, I think that we should be glad that the worst is over, that we have in fact survived this particular pandemic, that we have, there are consequences still, and these have to be looked after, but basically we've survived, and I think we should learn from what we have experienced and prepare ourselves for the future with much more joy, and knowing that we can deal with problems such as this and still survive.
Great. So we're up for all challenges, and there's always a way through. So thank you for that. And Hilke, right that we give the patient voice the last word.
Yeah. Okay. Thank you. Well, there's been years and years talking about importance of mental health, but not much has been done. So I think that we have to really start to take this seriously, and we have to add resources to mental health research and mental health care. But the most important thing is to pay attention to young people and children, and to help them to grow the resilience, so that I think that goes for the whole population, that from at school you can start mental health education for everyone, so that they are ready if we get this kind of crisis in the future.
Well, thank you so much, Hilke. Wise words. And I want to say a really big thank you to all our speakers. I think there's been a tremendous session, a really historic session. The session's being recorded, so it will be accessible, I'm sure, to many, many more people who will want to see this very valuable session. I'd like to thank everybody who has joined the session. Some very positive comments in the Q&A about how good the session has been. So thank you for that. Also like to thank the organisers, and Angela and Marissa, and also the college staff, Sarah and Agnes. So thank you so much for a wonderful session, lessons to be learned, but as Norman, you said, lots of positive things that we can take from this as well. So thank you, enjoy the rest of your day, and thank you to all of you for all you do. Thank you, goodbye.